number, you can chat with her, or you put it in the SSB group. You have a PGS group, we have a consultants group. You put we'll answer you there only. Okay? You'll get the appropriate answers. Thank you, Sonia. Thank you. If you're done with. I think I call upon Puneet to the stage. Come on to the stage. You have to. Request. Style nodi sir. Udugru ella. They are stylish only. They are stylish. Sit there. Yeah. Pudit is the judge for posters. We have 3 minutes for presentation, 1 or 2 questions, maximum maybe 5 minutes. And 7:30 we are closing. Okay? The time is 45 minutes, 7:30. I think I'll leave it to the faculty. You can start up, sir.
Yeah. Good evening, everybody. We will now start the poster session. The first one is by Dr. Nikita. Intraperitoneal inguinal hernia mimicking a Spigelian hernia. Over to you, Nikita.
Good evening, Honorable President, Secretary and members of Surgical Society Bangalore and my dear colleagues. I'm going to present a poster on intraparietal inguinal hernia mimicking Spigelian hernia. A 65-year-old female had complaints of swelling in the right lower abdomen since 6 years and noticed gradual increase in size since 1 month. The swelling was associated with mild intermittent pain, no history of bladder wall disturbances, weight loss or loss of appetite. She was a known case of hypertension and well managed. On examination, she was hemodynamically stable. On local examination, there was a soft, non-tender, partially reducible mass in the right lower abdomen as highlighted in the image. We have asked for a CECT as it was large swelling and it showed large defect in the right paramedian lower abdominal wall with bowel and mesentery as content, and it was reported as probable Spigelian hernia. Open surgery was planned in view of large Spigelian hernia. We went in with the right paramedian incision, but to our surprise it was not a Spigelian hernia as expected. The sac was found to be intraparietal in the space between external oblique aponeurosis and internal oblique. The sac was extending in the plane from the level of umbilicus to the right labium majus. A small bowel was seen as the content. On defining the sac, it was noted that it was extending to the deep ring and the defect size was approximately 5 centimeters. The sac was opened, contents were reduced and the neck was closed with bursting suture using Vicryl 2.0. The defect was reinforced by plugging 3 by 6 inch Prolene mesh and held in place with nylon sutures. Second mesh was placed over it to reinforce the posterior wall of groin hernia and sutured in situ to inguinal ligament and conjoint tendon with nylon. On follow-up, post-operative period was uneventful and patient was discharged on POD2. Suture removal was done on POD10. 3 months later, which is now, patient has no complaints and is doing well. Intraparietal inguinal hernias mimic Spigelian hernias clinically. The diagnosis is difficult rather than its treatment. 3 different subtypes of intraparietal inguinal hernia have been classified. They are preperitoneal, interstitial and superficial depending upon the plane of the sac. Interstitial is most commonest of them all. It was interstitial in our case. CT scan is generally the investigation of choice for these kind of presentations, but even CT scan was reported as Spigelian hernia. The treatment for this kind of intraparietal inguinal hernias is surgical exploration and defect repair. Thank you.
Good presentation. So this was femoral or inguinal?
Inguinal, sir.
It was not femoral. So why did you use 2 meshes there?
Sir, actually, though it doesn't show any significant difference, it was used to increase the fibrosis, sir, for the healing process.
What is Spigelian hernia?
It's a hernia from the Spigelian fascia, sir, through the through the semilunar line. So it's
Exactly what is the definition of Spigelian hernia?
the contents of the abdominal cavity herniating through the Spigelian fascia is called as Spigelian hernia.
What is exactly what is the anatomical identification of Spigelian fascia between?
It includes both the internal oblique and transversalis fascia, sir.
No.
Anybody? Postgraduates? The spigelian hernia is the hernia coming just under the arcuate line where the posterior rectus sheath stops. Anterior rectus sheath continues, posterior rectus sheath stops. So that is where the hernia comes out. So that is called spigelian hernia. Any other questions?
Can you clinically diagnose spigelian hernia?
Not sure, sir.
It's very difficult. You cannot diagnose clinically.
Any other questions from students? Right. Thank you, Nikita. The next poster will be by Dr. Praveen, neuroendocrine tumor presenting as a appendicocutaneous fistula.
Good evening, Honorable President, Secretary, and all the members of Surgical Society of Bangalore and my dear colleagues. I am going to present a paper on neuroendocrine tumor presenting as appendicocutaneous fistula. A 26-year-old woman came with complaints of right-sided abdominal pain, intermittent since 15 days, and complaints of pus discharge from the scar of C-section since 15 days, and there was no history of fever or vomiting, and no altered bowel and bladder habits. There was no medical comorbidities and no similar complaints in the past, and patient had undergone LSES 2 years ago. On examination, patient was conscious, oriented, and vitals were stable. On per-abdomen examination, abdomen was soft, non-tender, and sinus was present over the LSES scar. Patient came with investigations done elsewhere, and an ultrasound abdomen pelvis in the right iliac fossa there was distal half of appendix dilated, measuring 13 mm in maximum diameter, with appendicolite measuring 4 by 3 mm in size, and a small fistulous tract extending from the tip of appendix up to the skin, measuring 4.3 centimeters in length and 6 mm in width. CECT abdomen showed tip of appendix as bulky, fluid filled, measuring 13 by 12 mm, with 4 by 3 mm of appendicolite, and there was no periappendiceal collection, no nodes, and peripherally enhancing sinus tract noted in the right iliac fossa. Laparoscopic appendicectomy and wound exploration was planned. Intraoperatively, appendix tip was bulky and attached to the anterior abdominal wall corresponding to the region of anterior abdominal wall sinus. Base, mesoappendix, and mesentery were normal. After wide excision of peritoneum, there was no obvious fistular tract was found, hence wound exploration was planned, but wound exploration showed no stitch underneath. On histopathology, it turned out as a grade 1 well-differentiated neuroendocrine tumor with vascular neural invasion limited up to the mesoappendix at the tip, and base of appendix was clear, with occasional mitosis, and complete excision were confirmed. In view of size being less than 2 cm, that is 1.3 cm, and localized disease, patient will be kept under the follow-up. Appendicitis is one of the common cause of right lower quadrant abdominal pain, and the occurrence of appendicocutaneous fistula is extremely rare, and only about 40 cases are reported. Mechanism of formation of appendiceal fistula is spontaneous rupture of inflamed appendix into the adjacent bowel and obstruction to the appendiceal calculus, malignancy, or tuberculosis, preventing the spontaneous closure. Most common appendiceal tumors are neuroendocrine neoplasms, comprising 25 to 60% of primary malignancies, and most of the cases are incidental. They include well-differentiated, poorly differentiated, mixed neuroendocrine, non-neuroendocrine neoplasms. Management depends on various factors such as histological differentiation, disease stage, hormone production, somatostatin receptor expression, tumor burden. According to guidelines, when the lesion is less than 1 cm, it can be managed by appendicectomy, and lesion of 1 to 2 cm by appendicectomy with surveillance or right hemicolectomy, and lesion of greater than 2 cm by right hemicolectomy. As our patient lesion is 1.3 cm and localized disease, patient who underwent appendicectomy is being kept under surveillance. And chromogranin A, 5-hydroxyindoleacetic acid are used as biomarkers for surveillance, while somatostatin receptor PET scan is considered the gold standard in diagnosis and surveillance. Thank you.
Only neuroendocrine tumors can present with intracutaneous fistulas, or any other malignancies of appendix also can present with cutaneous fistulas?
Other types can present as fistulas, sir.
What
One of
tumors?
it is neuroendocrine tumors.
Now, what other malignancies of appendix can present as fistulas?
When there is inflamed appendix coming contact with the abdominal wall, it can present as fistula, sir.
So basic pathophysiology is because of inflammation, abscess, and it can give rise to intracutaneous
Yes.
fistula. So even adenocarcinomas, all these tumors
Yes, sir,
can also present with.
sir.
Most commonly is adenocarcinoma.
Yes.
Yes, sir.
The tumor in the appendix usually do not invade the abdominal wall. The cesarean section has made it to fix to the posterior abdominal wall.
Yes, sir.
That is why there is fistula.
Yes, sir.
So this is the Pulsitsky cell tumor. Pulsitsky cell tumor, that is same what you are telling, neuroendocrine tumor.
Yes.
Its prognosis is very good. If there is no lymph node, nothing to be done. Have you excised a part of the abdominal wall?
Yes, sir.
How much is your margin?
So I have done wide excision of peritoneum, sir.
What is white for you?
Sir.
But white may not be true for others. So that's why you should take at least a centimeter margin in this. Margin. I think this is white, good. And if there is no lymph nodes, no other lesion,
Yes.
the prognosis is very good. You have done a good job. Thank you.
Thank you, sir.
Any other questions? Thank you, Praveen. Now coming to the next poster, I think couple of posters here, underline the importance of multidisciplinary team meeting and concept of teamwork. This is one such case. I will now invite Vinod to present this poster.
Good evening to respected President, Secretary and members of Surgical Society of members. And my poster is on case of chronic pancreatitis with recurrent pseudocysts. 34-year-old gentleman who is a known case of recurrent attacks of acute pancreatitis had a multiple hospital admissions, had undergone procedures like endoscopic cystogastroscopy, multiple blood transfusions and embolization of left gastroepiploic artery for life-threatening hematasis. Was readmitted in another hospital for acute pancreatitis and melena, was investigated and CT abdomen and pelvis showed splenic vein thrombosis and a large pseudocyst of size 11 centimeters and multiple smaller collections in the body of the pancreas. And endoscopy showed multiple prominent submucosal veins, and now the patient has came with these investigations to our hospital, and we had a multidisciplinary team discussion, and our concerns was recurrent attacks of acute pancreatitis, weight loss and splenic vein thrombosis. And we have diagnosed it as acute and chronic pancreatitis with pseudocyst with splenic vein thrombosis, and exploratory laparotomy was done and intraoperatively found left-sided portal hypertension, pseudocyst with 250 ml of turbid fluid and hard distal pancreas. And we have proceeded with pseudocyst drainage, distal pancreaticosplenectomy with Roux-en-Y drainage of pancreatic stump and cholecystectomy. And Roux-en-Y drainage of pancreatic stump was on-table digestion, and we have done leak test and there was no leak found intraoperatively. And there was a 200 to 300 ml of fluid in the drain from POD3, and we have found food particles in the drain, and we have done CECT and extra gastrographin, and we have seen leak from the proximal stomach. And in the endoscopy, we found there is a gastric fistula of 15 to 18 mm, and we tried to close it with Ovisco clipping, but not possible as the posterior lip was fibrosed and adherent to the cystic wall. And hence, Freca tube was inserted, and we have started feeds through that, and patient was stable, hence patient has been discharged. And within 2 days, patient came back with the obstruction in the Freca tube, hence we proceeded with exploratory laparotomy and closure of gastric fistula and feeding jejunostomy. And there was a perforation of around 3 into 2 centimeters in the posterior gastric wall at the cystogastroscopy site. It was closed, and we have started on FJ feeds, and patient started on liquids from the POD5, and as the patient is stable, we have discharged, and drain was removed on POD7, and oral soft diet was allowed from POD10, and FJ was removed on POD20. And we have followed up the patient for 6 months, and there is no acute pancreatitis episodes, or there is no pain abdomen, and patient has gained a weight of around 6 kgs. And a study conducted by Pan et al. With a study population of 893 patients classified the pseudocysts into 5 types, and our case comes under 5A, which is a splenic vein thrombosis with a pseudocyst in the tail end of the pancreas, which was treated by distal pancreatectomy with splenectomy, which is done even in our case. Distal pancreatectomy with splenectomy is a choice of surgery for recurrent pseudocysts in the tail of pancreas with left-sided portal hypertension. Thank you.
Poster is open for discussion.
Yeah, I think it is a complicated case. Portal hypertension, left-sided portal hypertension is quite common in pancreatitis. First you told is acute pancreatitis. can you define between acute pancreatitis and chronic pancreatitis? What is the difference?
Acute is a patient having less than 6 days or 7 days, maybe for the first episode, and there is a fibrosis in the pancreas when it is converted into chronic pancreatitis.
Wrong. Most of us, we define pancreatitis wrongly. Acute is acute and chronic is chronic. Acute is, it is inflammation of the normal pancreas. And it has got its own way of resolving complications. Chronic pancreatitis occurs in a diseased pancreas. Disease means it is already diseased beforehand. There is fibrosis, there is ductal dilation. Chronic pancreatitis is defined as, if you really see, it is a chronic, irreversible inflammatory process characterized by ductal dilation, ductal stricture, stone formation, and generalized calcification or generalized fibrosis and microcalcification all around. And it will never come back to normal. Whereas in acute pancreatitis, it has got a chance to come back to normal, see, if there is no necrosis. If there is necrosis, it will never come back to normal. All right? Now, number two, you have not defined it acute or chronic. Number two, when there is portal hypertension, the surgeries become very bloody. Unless you know the trick. What is the trick? You ligate the splenic artery fast. So the inflow is lesser and the outflow venous return will be little, not so much of venous dilation will take place. It is because of splenic vein thrombosis. You have done a good job by doing a distal pancreatectomy. Have you left the spleen?
No, sir, removed.
But why have you not mentioned distal pancreatic splenectomy?
We mentioned.
You mentioned?
Yes.
I missed that.
Yes, I mentioned.
Yes, yes. And what have you done? Have you checked of the portal vein?
Yes, sir.
At what level you cut? You could see this thrombus in the splenic vein?
At the level of formation of.
When you transection level, you must see the splenic vein. Was there thrombosis or no thrombosis?
No thrombosis.
So you cut this pancreas at the level where there is no thrombosis.
Yes.
I think that's the correct method. Thank you very much.
Thank you. So, Vinay, any questions? Thank you. We'll move to the next poster. This is another very good example of intense monitoring and timely intervention, damage control surgery, and involvement of multiple teams and teamwork. Over to you, Pavan.
Thank you, sir. Good evening, respected President, Secretary, members of Surgical Society of Bangalore, and my dear colleagues. I am going to present an interesting case on gastric volvulus. We had 20 years female who came with complaints of upper abdominal pain since 1 week, associated with multiple episodes of non-bilious vomiting and retching. She had no medical comorbidities and previous surgery. She was ill with tachycardia and tachypnea with reduced air entry on respiratory examination. Abdominal examination, blood investigations, and ultrasound abdomen were normal. Upper GI endoscopy showed grossly dilated and distorted stomach, suggestive of gastric volvulus, and a rare possibility of pyloric obstruction was also entertained. Chest X-ray showed large gastric bubble with gross right mediastinal shift, and no fundal shadow was noticed. CT confirmed left bogdalic hernia with organoaxial type of gastric volvulus. We did thoracolectomy and distended stomach occupying the left hemithorax with compromised vascularity was noted intraoperatively. The contents of the stomach was reduced into the abdominal cavity and the repair of the diaphragm was done and left-sided ICD was placed. Correction of the gastric volvulus was done and it was decided to do laparostomy as the viability of the stomach was in doubt. In view of severe pulmonary compromise, patient was electively ventilated. Next day, the patient has continued to be tachycardia, hypotension, metabolic acidosis and septic shock. She was re-explored earlier than planned and found to have gangrenous stomach. Hence, we did subtotal gastrectomy. In view of hemodynamic instability, we have decided not to do anastomosis. Instead, laparostomy was done. Patient was improved. Later, we did gastrojejunostomy, jejunojejunectomy and feeding jejunostomy. She had a difficult post-operative period and could not be weaned off from the ventilator and tracheostomy was done on day 7, and on the same day ICD was removed. She had persistent tachypnea. We took pulmonologist opinion, CT thorax showed left-sided pleural effusion, hence ICD was reinserted under ultrasound guidance. And eventually she got better and got discharged on day 27. Gastric volvulus is defined as abnormal rotation of the stomach around itself, and it is a rare condition and its exact incidence is unknown. It can be classified into organoaxial and mesenteroaxial type, and 30% of the cases occurs as primary event. Stomach necrosis occurs in 5 to 28% of the cases. Of this, 30 to 50% of the cases had mortality. Emergency exploratory laparotomy is required, and if vascularity is compromised. Hence, total gastrectomy or subtotal gastrectomy was also indicated. Thank you.
What is the simple test to say this is volvulus or just a stomach in the mediastinum or chest?
Sir, inserting a Ryle's tube, sir.
Absolutely correct. Absolutely correct. If you pass a Ryle's tube, it is going and is jetting out fluid or gas. You know, volvulus is getting reduced. Then you can plan for an elective surgery. If it is not going, emergency surgery. What I have got a little criticism is the stomach has gone from the abdomen.
Yes.
All right. The hole is there in the abdomen, in the diaphragm. You, even if you do a abdominal operation and continue to the thorax, laparotomy, you are not gaining anything. If you do same thing in the laparotomy or subcostal incision or something, I think you could have done the same job. I had a similar case.
Sir. Pavan.
Yeah. I had done a similar case. We could not pass the Ryle's tube. We just did a laparotomy.
Yeah.
Sir, can you repeat the question? I didn't get it, sir.
Why did you?
Yes.
Why not just a laparotomy?
Because the diaphragmatic defect is so narrow, so we can't able to reduce the contents into the stomach, sir. So we widened it and we reduced the contents into the abdominal cavity.
Very simple. Very simple. You pass it in the antrum is outside the pylorus is inside the abdomen.
No, sir. Entire stomach is inside the thoracic cavity, sir.
Then duodenum must have gone there.
What, sir?
Duodenum must have gone there.
Okay, sir.
That's exactly I am telling you. So make a small hole, pass a tube, soak it out.
Stomach was not very dilated. I think it was just.
Sir, it was not just the distension that was preventing the stomach from coming back. It was the adhesions around this bogdalic hernia. It's a chronic hernia. It must have happened at childhood, and from there up to the age of 20 or whatever, this patient has had a hernia, and it underwent volvulus only recently. And it was also, remember, a 7-day history, which means the whole thing was very stuck, and we were not happy about the vascularity. We didn't want to pull it down. So the classic teaching is, instead of pulling something into a thing, we extended the incision to the thorax, extended the hole that was the diaphragmatic hernia, and pushed the contents down, so that making sure that we do not cause any further damage. We felt that that was the most safe thing to do in these situations.
Thank you.
One point. If there is adhesion to the stomach, it will never do a volvulus. If there is adhesion surrounding, no volvulus.
Thank you, Dr. Pujari. Wonderful comment about the Ryle's tube passing. What are you going to do if you have another case like this? What is the plan? What is the idea? Because we need to learn from this. So it happens rarely, once in probably we see a couple of cases every year as a surgical gastroenterologist. What will be the plan next time?
Sir, if the patient is stable, we can go with the procedure, but in this case, we did damage control surgery, sir.
Fantastic. Damage control surgery. Our experience has been most patients with this kind of a picture have gastric volvulus, have vascular compromise, and end up requiring either subtotal or total gastrectomy. And we do it in the first sitting itself, just for the benefit.
Thank you.
Okay, just think of that.
Thank you. Next, The next poster is presented by Dr. Indraja. It's a rare salivary tumor of the lung.
Good evening, respected President, Secretary, and members of Surgical Society of Bangalore, respected teachers, and my dear colleagues. I am going to present a case of salivary tumor in the lung. A 28-year-old male software engineer came with complaining of hemoptysis since 3 months, intermittent, streaky more in the early mornings. Patient had no other symptoms. He had a history of hydatid cyst in the left lung upper lobe, underwent left thoracoscopy and excision of the hydatid cyst. CT chest showed soft tissue density mass noted in the superior segment of the right lower lobe, and there was also left upper lobe bronchiectasis. CT guided biopsy of right lower lobe mass suggested neuroendocrine tumor, and Dutinac PET CT showed well-defined heterogeneous enhancing lesion in the superior basal segment of the right lower lobe. With the above findings, we proceeded with the surgery. Intraoperative bronchoscopy showed tumor infiltrating between the middle and lower lobe bronchus, and there was 6 into 4 centimeter lesion in the hilum, aborting the bronchus intermedius with multiple subcarinal lymph nodes. In view of difficulty in separating the mass, thoracoscopy was converted to thoracotomy, middle and lower lobectomy with mediastinal lymphadenectomy was done. Postoperative period was uneventful. ICD was removed on postoperative day 2 and patient was discharged on postoperative day 3 and he is on regular follow-up. On grasp pathology, resector margins were free of tumor. Immunohistochemistry showed solid sheets of cells admixed with mucous cells and the mucin was positive for periodic acid skip agent. Immunohistochemistry was positive for cytokeratin and P40 in the favor of mucoepidermoid carcinoma. CD56 was patchy positive, but chromogranin and synoptophysin were negative, which ruled out neuroendocrine tumor, and thyroid transcription factor was negative, which ruled out primary adenocarcinoma of the lung. Final diagnosis was mucoepidermoid carcinoma intermediate grade. It is rare salivary tumor in the lung. Incidence is 0.1 to 0.2% and affects males and females equally. The origin is endobronchial, most commonly seen in the central airways. Diagnosis mainly depends upon the histopathological examination and immunohistochemistry. Histologically, it has 3 grades, low, intermediate and high. Complete surgical resection is the treatment of choice and the role of chemotherapy and radiotherapy remains controversial. To conclude, mucoepidermoid carcinoma in the lung is very rare. Complete surgical resection is the treatment of choice. Thank you.
Thank you, Indraja. Now, poster is open for discussion.
Mucoepidermoid carcinoma, prognosis?
Sir, prognosis associated with lymph node involvement and positive resector margins.
No, is it a aggressive growing tumor? Is the prognosis very dismal, very bad, or is it
no,
good?
Low grade tumors are better prognosis, sir. If it is high grade,
This was a low grade tumor. So the prognosis is, I think, pretty good.
What are the types of salivary tumors which can occur in lung? One is mucoepidermoid, other one is adenoid cystic.
Do you want to call it from the lung? Or I would still say probably from one of the
It's in the right bronchus, in the right lower lobe apical segment. So it's a tumor in the lung parenchyma. But final histology is mucoepidermoid. Mucoepidermoid is a common tumor of the salivary gland. That's all. In this patient, prognosis is good because it's a limited disease, R0 resection, lymph nodes not involved, and it's a low-grade tumor.
So even adenoid cystic can occur and they are more in the primary bronchus.
Yes.
Mucoepidermoid arising.
In fact, adenoid cystic carcinoma is the second commonest tumor in the trachea.
Adenoid cystic will occur in main bronchus and trachea.
Mainly main airways are involved in adenoid cystic carcinoma.
Mucoepidermoid in the distal bronchus.
Thank you.
thanks.
Now we will move on to the next interesting case of isolated intraperitoneal rupture of the bladder. Dr. Nikita.
Good evening, Honorable President, Secretary and members of Surgical Society Bangalore and my dear colleagues. I would like to present a poster on isolated intraperitoneal bladder rupture. A 28-year-old gentleman presented to us with diffuse abdominal pain following a fall from his motorbike the previous day. On examination, patient was hemodynamically stable. There were no focal neurological deficit. Abdominal examination revealed minor superficial abrasions and on palpation it was soft, non-tender, there was no distension, cording or rigidity. External genitalia and parietal examination had no positive findings. All blood investigations were normal except serum creatinine and total count which are elevated. CT abdomen and pelvis was done which showed irregular outline of upper pole of spleen, suspicious of splenic injury and moderate amount of free fluid in peritoneum, suspicious of hemoperitoneum. No pelvic fractures were noted. IV contrast was deferred in view of elevated creatinine and oral contrast was advised. 14 French Foley's catheter was reinserted, mild hematuria was noted, so bladder wash was given with normal saline which showed 2 minor clots. Physician and urologist opinion was sought. In the meanwhile, patient took the oral contrast and CT oral contrast was done which showed small pneumoperitoneum and no other solid organ injuries. So we immediately went for a diagnostic laparoscopy in view of hollow viscous perforation. Intraoperatively, we found there was a transverse rupture of peritoneal dome of urinary bladder of approximately 8 centimeters and was identified and without any damage to other intra-abdominal organs. The bladder was sutured laparoscopically in single layer using PDS 20. Peritoneal lavage was done. Leak test was performed which was negative. Postoperative period was uneventful. Serum creatinine and total counts reduced gradually and patient was discharged on POD2 with Foley's catheter in situ. On follow-up, after 2 weeks, patient was doing well. Foley's catheter was removed then and he passed urine an hour later. Points to ponder, in this case, CT plane showed no pneumoperitoneum but oral contrast CT after catheterization and bladder wash showed pneumoperitoneum, maybe due to the air entry during the wash. Patient was intoxicated at the time of fall, probably with a fully distended bladder which resulted in bladder rupture. This was retrospectively questioned and found out. Isolated urinary bladder rupture caused by blunt abdominal trauma is infrequent injury with less than 2% of all the abdominal trauma cases. Diagnosis of bladder rupture is generally delayed in the absence of pelvic fractures or injuries. Ultrasound and non-contrast CT are unreliable in these cases. Plain film cystography and CT cystography are specific and sensitive. Intraperitoneal bladder rupture, surgical exploration is advised as they cause high risk and pose more morbidity and mortality. In contrast, extraperitoneal bladder rupture is commonly managed non-surgically with urinary catheter drainage for up to 3 weeks. Thank you.
Paper is open for discussion.
What is the most common reason for intraperitoneal rupture of bladder? You mentioned, can you tell us again?
Abdominal trauma, sir.
No. Yeah, abdominal trauma, but why does intraperitoneal rupture happens? You already said.
Intoxication, sir.
No, not intoxication. It should be a full bladder.
Distended bladder.
Yeah, and it occurs common site is? You again mentioned that.
Dome of the bladder.
Because that will be the
One
weakest
important
part.
history you have missed, doctor. Patient will not have desire to pass urine, nor he will pass urine. That point is the sole history that you suspect is intraperitoneal injury.
Yes.
After that, you find free fluid in the peritoneal cavity. The gas is artificial, created because of this thing. But the history is no desire to pass urine, even if you give more IV fluid. That is the thing, which is interpreted.
Yes, sir. I think that is a very good point. Postgraduates, please.
I'm
note
Dr.
that.
Ray. You see, I became surgeon much before the ultrasound came. Actually, I am very fond of, whenever I see some amount of collection in the abdomen, I'm talking about the pre-ultrasound area, I used to put a needle to see what is it. Is it bile? Is it blood? Is it fluid? And today we have got ultrasound where you can be guided, you can not go in a blind way. Just put a needle itself would have given you the diagnosis and everything would have been fine.
Sir, but the diagnostic peritoneal lavage is now given up. I don't think anybody.
No, I'm not talking of the peritoneal lavage. I'm just telling you can see the collection, put a needle, aspirate it. That's all. I'm not talking of the lavage.
Yeah, definitely. It's one of the things.
If you aspirated it, I have got the case like this. Whatever he said is exactly like one child with the door fell down, same thing. You just put a needle, you can't get this one fluid, send for the urea. If it's positive, immediately you know it's urine. You have to know whether it's a blood, whether it's a normal fluid, whether it's a urine, whether it's a bile.
Agreed, sir. But the time lag.
We'll move on to the next poster, please, for the lack of time.
Yeah, the time lag between the patient coming to the casualty to patient being subjected to diagnostic laparoscopy was only 8 hours. She's just given the story, but so there was no delay in the management of the patient. But your point is well taken. Thank you, sir. Thank you. Next, move on to a large cranial vault intraosseous hemangioma. This is presented by Dr. Praveen.
Good evening, respected President, Secretary, and all the members of Surgical Society of Bangalore and my dear colleagues. I am going to present a poster on large cranial vault tumor, that is intraosseous hemangioma. A 49 years old gentleman came with complaints of swelling over posterior aspect of it since 2 years, gradually increasing size and associated with generalized headache and pain within the swelling. There was no history of vomiting or limb weakness or trauma, and there was no similar complaints in the past, and patient was no case of diabetes. On examination, patient was conscious, oriented, and GCS were good. On local examination, there was large hard bony swelling over the hospital part of head, size measuring 7 by 7 centimeter. On CT brain, it showed hospital bone in midline with a large well-defined, mildly lobulated, mixed osteolytic and sclerotic lesion measuring 43 by 70 by 70 mm with no intracranial extension and no mass effect or edema with an impression of intraosseous meningioma. We had planned for the craniotomy and en-bloc excision. An occipital inverted U-shaped scalp flap was raised up to the posterior arch of atlas, and intraoperatively there was highly vascular tumor in the occipital bone in the midline size of approximately 10 by 10 centimeters, and tumor was firmly adherent to the torcula. Craniotomy and en-bloc excision was done with 5 mm distance all around the tumor margin. Tumor was separated from the superior sagittal sinus, both transverse sinuses and occipital sinus, and bleeding present from the torcula was controlled by gel foam, Surgicel and Flosil. And titanium mesh cranioplasty was done. On histopathology, there was extensive areas of hemorrhage and vascular channels of varying sizes, and on immunohistochemistry, the CD31 was positive and CD34 was positive, suggesting of angiomas. And the final diagnosis was benign intraosseous vascular neoplasm features consistent with intraosseous hemangioma, and a second opinion was taken which proved the same. And these are the follow pictures after 1 week and 3 weeks. Patient was doing well without any complaints. Intraosseous cavernous hemangioma consists of blood-filled sinusoidal channels lined with a single layer of flattened endothelial cells contained within the bony trabecula. Primary intraosseous cavernous hemangioma are a rare and infrequent tumor, usually more common in the spine and rare in the cranial vault. In skull, they mostly involve in the frontal, followed by temporal and parietal bones, rarely in the occipital. Most of the time, they are asymptomatic and are usually incidentally detected. The first description of this type was given by Toyn B, and from then, in the review of literature, only about 100 published cases of hemangioma in the skull was found, and about only 10 reported cases of hemangioma in the occipital was found. Treatment of choice is an en-bloc resection with 5 to 10 mm of wide bone margin. Thank you.
Thank you. Thank you, Praveen. Paper is open for discussion.
What were the post-operative complications you had explained to patient?
Sir?
Here.
Post-operative complications which you explained to patient.
Usually bleeding is a more common complication in the surgery, sir. So I have explained it, sir.
No any other no any neurological deficits which you need to explain, or this can be avoided in this surgery?
We have explained it, sir.
No, what?
Based on the region of the tumor, according to the deficit.
So this patient had no complications?
No deficits, sir.
Any other questions? Manmeet, Dr. Manmeet, our neurosurgeon, is here. Would you like to comment anything special for the understanding of the postgraduates?
I am Dr. Manmeet, neurosurgeon. So this is a very rare case. Till now, as he has told, only 100 cases, and in this location only 7 to 8 cases are there. So the problem is we cannot go through the tumor in this case. If we go through the tumor, it will bleed like hell. So even if we embolize, this will not, the idea is to remove it end block with a normal margin of normal bone all around. And it will be adherent, it will be draining, it will be having blood supply from the external carotid artery, and it will be draining into the sinuses. And it was densely adherent, we were aware of that. There was a nice 1 centimeter punch in the torcilla. Torcilla is the confluence of sinuses, which is one of the most vascular areas of the brain, where you cannot even suture it. So you have to plug it with gel foam only. So that's the main thing, where we had a lot of bleeding during surgery. Almost 7 to 8 units of blood were transfused. That is very rare in neurosurgery. And still the patient made it. He is doing quite well.
Yeah, thank you. We have the last poster now. Thank you, Manmeet.
Thank you, sir.
Inflammatory myofibroblastic tumor of the neck by Dr. Indraja.
Good evening, respected teachers. Good evening, respected President, Secretary, and members of Surgical Society of Bangalore, respected teachers and my dear colleagues. I am going to present a case of inflammatory myofibroblastic tumor of the neck. 47-year female came with complaining of swelling in the right side of the neck since 2 years, which was slowly progressive, not associated with pain. On examination, there was single, non-mobile, non-tender swelling of size 5 into 5 centimeters present in the right posterior triangle of the neck, posterior to the posterior border of sternocleidomastoid with ill-defined margins. On ultrasound neck, there was large lesion in the right side of mid-neck with internal vascularity, and there were also 2 nodules in the left thyroid lobe. FNEC showed benign nodule in the left lobe thyroid and spindle cell lesion in the right neck swelling. On MRI neck, there was heterogeneous lesion in the right side of the mid-neck in the posterior cervical space posterolateral to the right carotid bulb, suggestive of neoplasm. Initially, we considered either vagal schwannoma or spindle cell neoplasm and proceeded with the surgery. Intraoperatively, there was large tumor compressing the internal jugular vein and internal carotid artery, and the tumor was excised completely. On histopathology, there was spindle-shaped cells with collagen bundles with infiltrated lymphocytes and plasma cells with vascular and mixed background. These are the characteristic features of inflammatory myofibroblastic tumor. Immunohistochemistry was positive for smooth muscle actin and desmin, and CD138 highlights plasma cells which confirm it as inflammatory myofibroblastic tumor, and ALK1 associated with the prognosis of the tumor. Positive indicates better prognosis and negative indicates poor prognosis. Final diagnosis was ALK negative inflammatory myofibroblastic tumor. It is defined as unique intermediate soft tissue tumor with fibroblasts infiltrating plasma cells, lymphocytes and eosinophils. Incidence is 5% of total head and neck malignancies. Most of the patients present with masses without any systemic manifestations. WHO defined it as clear low-grade malignant tumor, and pathology is the gold standard for the diagnosis. Surgical resection is the main treatment of choice. Postoperative radiotherapy and chemotherapy indicated in patients with incompletely resected or with positive resected margins, and it has high local recurrence rate even after complete excision. This patient was followed up with medical oncologist who advised to undergo PET-CT to look for the residual disease and metastasis, but it was normal, and medical oncologist advised to undergo radiation in view of high local recurrence. To conclude, inflammatory myofibroblastic tumor is rare in the head and neck region, and surgical resection is the main treatment of choice, and it has high local recurrence rate. Thank you.
Thank you. Judge,
Is PET scan compulsory in this patient?
Sir, to look for the metastasis, sir. And
No, so it's. Do you think it has malignant potential?
Yes, sir.
Any opinion?
No, I think the PET-CT is not necessary, but it was done by the medical oncologist.
But this was low grade, and even radiotherapy is indicated in this case.
High low.
I think good surgery is the cornerstone for treatment. That should have sufficed.
Yeah.
Thank you.
Thank you. I think we should congratulate all the postgraduates who have presented it on time, and we have completed
Exact, on the date. Thank you, Rajshekar Reddy sir, and the Judge Puneet. Thank you. Ravi to stay back. So please.
So we'll begin with the second part of the academic sessions, the paper sessions, and as usual before the paper sessions we have the surgical canopies by Dr. Prem Kumar. But before all that happens, it's my honor to again welcome the President of Surgical Society of Bangalore with the Presidential Medallion.
Thank you all. Thanks for coming. The crowd is increasing month by month. The monthly clinical meeting right at 6 o'clock, we had a good crowd of students and the faculty. I welcome all of you, especially the Sagar is hosting this month. They have especially with faculty like Ravi sir, Lakshman sir, and all the faculty here, Rajshekar Reddy sir. We are going to have an academic extravaganza today. Perfect presentation.